My name is John Peller with AIDS Foundation of Chicago, and we are covering today Marketplace 101s as part of the We Can Do It New Basics of Health Reform for Frontline HIV Workers, that's a mouthful, webinar series. And joining me is Melinda Elwood, who's with the Center for Health Law and Policy Innovation at Harvard Law School. Melinda is going to be fielding questions and helping me to answer them. We cannot take questions live today because we have, at this moment, 250 people listening in on the webinar. So we ask that you submit them using the questions feature on your little window that pops up next to the webinar window. And we will stop and answer them. And then go to the next slide. If you're having trouble hearing the audio, you're probably listening through your computer screen. You should call in with your telephone. And so you'll see the little audio area here of your window. Click on that to open it up, and then click the Use Telephone button and dial the phone number and access code there to see, and you'll get there on your phone. We encourage you to download the slides and resources. If you go to HIVHealthReform.org, you'll see a post on the homepage that says, it'll actually say download the slides right at the top and have the We Can Do It logo there. So click there, and we have lots of resources there and links to information about the Affordable Care Act for immigrants, trans health coverage. We have a couple of really good videos and links to related webinars that we have done. So please go ahead and download the slides. Go ahead. So we encourage you to register for a couple of upcoming webinars. We have gotten highly organized today, and we've posted the registration for 2 of the 3 upcoming webinars. October 23rd is going to be a Medicaid Expansion 101, and Thursday, November 14th, is Strategies for States Not Expanding Medicaid. And you can register for those at HIVHealthReform.org/webinars. We will be sending out an email with that link. We also, just so everybody knows, we archive the recordings on HIVHealthReform.org. So if you want to go back and listen to this because you think it's so fun and wonderful and brilliant, just kidding, you can do that. And this project is supported by an educational grant from Janssen Therapeutics, division of Janssen Products, LP. Continuing education credits are not available. So I've done my disclosure. So this is really important. This is a 101 basic webinar. We're not going to go too in-depth on some topics, and there may be some overlap with past webinars. So if you feel that you know marketplaces inside and out, this might not be the webinar for you. So just keep that in mind. The other caveat is that we cannot provide a lot of state-specific information. We get a lot of requests for people who say, please provide more information about what's happening in your state. Well, unfortunately, it's Melinda and me and sometimes a couple other folks, and we just don't have the resources to provide state-specific information. We really, really wish we could, but unfortunately we can't. So just please understand that. Go ahead. So just please check out some recent webinars that we've done that have some overlap with today's topic. We did one on October 1st about how to pick a health plan, which goes into some really terrific details. We had the first webinar in this series, which is a health reform overview. We did a webinar on open enrollment. So all of those recordings are posted at HIVHealthReform.org. All right, and now we're getting to the meat of today's topic, and we are going to cover the marketplace and how it will help people with HIV, how will clients afford the marketplace, how does ADAP work with the marketplace, and then talk a little bit about how clients pick a plan. So it's really important to keep in mind that we are seeing a lot of bumps in the road, and this is not really surprising given how massive healthcare reform is. And many of you have probably tried to log on to healthcare.gov and gotten that message, try back later. And yes, it's been incredibly frustrating. We in Illinois have not been able to look at the plans in our state, which is, it's really frustrating. But ultimately, this is a good thing, and it shows just how much demand there is and interest in healthcare reform there is out there, and how much need there is. This demand is going to slow down. And remember that October 1 is just the start of open enrollment. The real deadline that we need to keep in mind is December 15th, and that's for coverage that will start on January 1. So you have the rest of October, you have November, and you have the first part of December to do enrollment. And we know the government is doing everything it can to expand capacity and make sure that everybody who needs to can enroll. And keep in mind that if your state is expanding Medicaid, you probably will be able to enroll people in Medicaid on state websites. So don't not enroll people in Medicaid. So another thing to keep in mind is that we have achieved something that we have been fighting for since 1981, for 32 years, since the first announcement or report of what we now call AIDS, and that's expanded health coverage for not just everybody with HIV, but everybody with a chronic condition, everybody who is uninsured, everybody who needs insurance. Of course, there are some exceptions because the law is not perfect. We're taking a huge, massive step forward on January 1 of 2014. But just remember, there are going to be problems, as we've seen already. And we don't want to sugarcoat things. It's not going to be perfect. We know that there's going to be formulary problems, there's going to be network problems, there's going to be people who find healthcare just not affordable. And we need to work through these problems, solve them together, and keep working to improve healthcare reform. So there are two major health reform programs that we are going to touch on in the webinar series that are really critical for people with HIV. The first is Medicaid expansion, and this is not what we are focusing on today. There are 25 states that have already adopted Medicaid expansion. We are covering Medicaid expansion on a webinar on October 23rd, but we are covering private insurance marketplaces. And these are websites where you can browse and select private insurance plans. And if your state is not expanding Medicaid, if you are one of those 25 that are rejecting Medicaid expansion, marketplace coverage is really important for you to understand, because it's a critical way to fill gaps for many people with HIV, and particularly with help from ADAP. And we're going to be covering that in November on another webinar in more detail. So we are, Melinda, do you have anything you want to add before we keep going?
No, I think that's exactly right. You know, this is an incredibly exciting time, and as tempting as it is to be sort of pointing out all the flaws, which I think are very important as we move forward, because we want to make sure that we are also keeping in mind how we need to improve the system. I think it's a great thing, and we need to try to be patient while at the same time trying to help everybody access the best plan they can.
Great, thank you. So please, as we go, keep sending questions in. We would appreciate that, and we'll stop and take them. So go ahead. All right, so we said we weren't going to cover Medicaid expansion, but okay, we got to talk about it for a second. So this is the map that shows Medicaid expansion. It's from Kaiser State Health Facts website, and the dark or the very light blue states are ones that are not expanding Medicaid at this point. The lighter blue states, or maybe the more blue, this map is not the best colors, are the states that are moving forward with Medicaid expansion at this time. And you'll see that it looks very much like a map of who supported the president in the last elections, and very red state, blue state, not surprisingly. Pennsylvania, I'm not sure why it's still blue. They are, it looks like Pennsylvania is moving forward although there's going to be a long and complicated process to make that happen. So it's really important for everybody to understand where their states stand with Medicaid expansion. So what is the marketplace that we're going to be talking about today? Starting October 1, people in every state can purchase health insurance through online marketplaces. And they're essentially one-stop shops where you can compare plans based on the coverage that they provide, the price, and eventually in the future, the quality. You can purchase coverage, and you can also get subsidies to make insurance more affordable. And the subsidies are available for people between 100 and 400% of the federal poverty level. Families are eligible, too, for marketplace coverage. We get a lot of questions about Medicare supplemental plans. They are not available on the marketplace. So just keep that in mind. Medicare supplemental plans cannot be purchased through the marketplace. So who is eligible and who's not eligible for coverage on the marketplace? First of all, anyone who is a U.S. citizen can buy marketplace coverage. In addition, there are a lot of categories of immigrants who are allowed to purchase coverage on the marketplace. And we posted a list, which you can find on the post on the homepage of our website, HIVHealthReform.org, with a complete list of all the covered categories. So we encourage you to look at that. And then no matter what somebody earns, they can buy marketplace coverage. So if Oprah wanted marketplace coverage, she could buy it. Of course, she could probably buy the marketplace if she wanted, but she could also buy coverage. And individuals who are uninsured family members of somebody who has employer-based coverage can also buy insurance. So say a mom has coverage through her employer. Her husband is, however, uninsured. He can go onto the marketplace and buy coverage, and he could buy coverage for his kids, for their children, or just for himself. So who cannot buy coverage? So primarily anyone who has other insurance, and we'll talk about this in a couple of slides, but anyone who already has Medicare or Medicaid cannot buy insurance through the marketplace. Anyone who has affordable employer-based coverage, we'll talk about that in a minute, and also anyone who is undocumented. And that is one of the greatest flaws with healthcare reform, that undocumented individuals are barred from buying marketplace coverage or getting Medicaid coverage. So let's talk for a minute about marketplace eligibility in Medicaid expansion and non-expansion states. And there's a key difference between the two. So in Medicaid expansion states, Medicaid will cover individuals up to 138% of the federal poverty level. They'll also be eligible for Ryan White services, but not ADAP. And then the marketplace will kick in at 139% of federal poverty, and folks will be eligible for subsidies to afford their coverage. In non-Medicaid expansion states, there's a key difference, which is that marketplace eligibility, or I'm sorry, subsidies for the marketplace begin at 100% of federal poverty level, as opposed to 138% in the marketplace. So lower income individuals between 0 and 100% of poverty are going to rely on ADAP and Ryan White, whereas individuals from 100% to 400% will rely on the marketplace in addition to Ryan White services. There are some really critical protections for anyone in the marketplace that result from healthcare reform. And these are really writing a long, long history of wrongs that have been conducted completely legally by the health insurance industry. So plans will not be able to charge higher premiums because somebody is a woman or because somebody is sick. These are practices that were entirely legal. Plans are going to be required to sell insurance to anyone who applies for it, even if they're sick. So people with HIV who were excluded from coverage because they had a pre-existing condition will be able to get insurance. Plans can't have lifetime or annual limits on the amount of benefits they'll pay. Really critical for people who have very serious illnesses, including HIV or HIV in addition to other illnesses such as cancer or have an accident. Plans have to contract with essential community providers, including Ryan White programs, so there are some network adequacy requirements. And plans have to present information in a standard format to make it easier to compare plans and make it, honestly, harder for them to hoodwink you into buying coverage that you don't want. So we really encourage you, and here's Dora exploring a birthday cake, to go and check out your marketplace. And this is kind of hilarious, but I couldn't get on the federal marketplace, so I thought, okay, so what's a smaller state that has their own marketplace? I went to the Kentucky marketplace site, and lo and behold, it's working just great. So I spent a while browsing plans in Kentucky, and their marketplace, you know, you can get on the site, it's easy to find plans. So I really encourage you, take some time to look at your marketplace. If you have to register to look at plans, go ahead and register. You can register and pretend you're shopping for insurance even if you're not eligible. And you can just, you know, answer some of the questions in the opposite way so that you can look at coverage options. There's also a really good video that we posted on HIV Health Reform that's about 15 minutes long, and it walks through the marketplace sign-up process and how to pick a plan, and it's very helpful. So, Melinda, so just a reminder, please send us questions. If you can't hear, you can click the audio tab and dial the number. And the slides are posted at HIVHealthReform.org at the top of the page, so you can get them there. And we will be sending out a link to the slides again, as well as a recording in the next couple days. So, Melinda, are there any questions that we have you want to take?
No questions yet about this portion of the webinar, but I do want to, there was a question which I think is a really good one, and I want to let folks know that we will get to it later in the webinar, which is sort of when will we know which plans in a given state are going to be compatible with that state's ADAP program. And the answer is we don't know. And John will talk a little bit more about that later in the webinar, but I just wanted to flag that because a couple of folks have asked.
Great. It also, okay. Well, let's go on, and maybe this question that just came in will be answered as we go. So, okay, so what are some general things that you need to know about the marketplace? And can we just look at Princess Leia here and how awesome she is? Okay, thank you. So we're going to show this slide a couple times because it is a pretty important concept to understand, and we have to come back to it a couple times. So there are different what's called metal levels. There's bronze, silver, gold, and platinum. And these correspond to what's called the actuarial value. And the actuarial value is how much a health plan might pay for a typical person. So it's not based on the individual, but it's a typical person who might buy coverage. And with each of these metal levels, so bronze, silver, etc., there are different cost sharing and premium levels. So with the bronze plan, you can expect to pay about 40% of the cost of coverage out of pocket in deductibles, co-pays, and co-insurance. Your premiums and plus what the plan pays will cover about 60% of the expected benefits. So you keep going up until you get to the platinum plan, and with that plan you can expect to pay about 10% of the expected cost of care out of pocket, again in premiums, I'm sorry, not in premiums, in the deductible, out-of-pocket costs like co-insurance, and your premiums will be higher. And there's a trade-off here between higher premiums and lower out-of-pocket costs. And this will become a little more clear as we cover some other other levels. But anyone who has very high medical expenses, and because we have the ADAP program, this is a little bit less of a consideration for people with HIV. But in general, people with very high medical expenses may want to consider the Platinum plan because they may end up paying less out of pocket. Next. So let's talk for a second about the enrollment timelines. We talked about the fact that enrollment began on October 1, and you have to enroll by December 15th to get coverage on January 1. So if you, coverage begins the month after you begin enrollment, or I'm sorry, after you sign up. So if you enroll if you enroll January 2nd, your coverage would begin on February 1. If you enroll on the 16th of January, your coverage will begin March 1. So depending on when you enroll, there's a lag in when coverage begins. And open enrollment ends for the marketplace on March 31st. So that is the absolute deadline for people who are eligible for the marketplace to sign up. And open enrollment will end, will open again in October of 2014. So it's important to know that clients can get ADAP and Ryan White if they miss open enrollment, and you as a provider document what you did to help clients enroll. HRSA has put out a number of policy statements that elaborate on this, but the general idea is that we as providers need to work really hard to get people with HIV to enroll in whatever coverage they're eligible for, but that the Ryan White program can serve as a safety net and should serve as a safety net. It's also important to remember that clients can enroll in Medicaid at any point. There's no open enrollment period for Medicaid. Medicaid eligibility or enrollment is continuous. So the individual mandate. Michaela is not happy about the individual mandate. All right, this is like a meme from a year ago, but hey, I was desperate. It was getting late. So one of the more controversial aspects of the Affordable Care Act has been that everybody has to have insurance. And basically, this is how insurance works. You don't want people buying car insurance after they get into an accident or buying homeowners insurance after they get robbed. The insurance system would just not work. So we want people to get coverage as early as possible. We want them to buy comprehensive coverage. And so in order to incentivize this, there are both carrots and sticks. We'll talk about some of the carrots, the incentives, when we talk about premium support, as well as cost-sharing reductions. But there are penalties that you do need to be aware of. They start small, $95 in 2014, and they rise to about 2.5% of income over time. So you could pay 2.5% of your income when you file your taxes if you can't prove that you have insurance. There are some exemptions. There are religious exemptions. There are certain sects that it's against their religion to have health insurance. Your coverage might not be affordable. If it's more than 9.5% of your annual income in premiums, your coverage is considered to be not affordable, and you can get a hardship exemption from your marketplace. And then if you're undocumented, or if you live in a state that does not expand Medicaid, you don't have to have insurance. So what counts towards the mandate? What coverage qualifies you as being insured? There is, first of all, employer coverage, but it has to be affordable. So premiums have to cost less than 8% of your salary, and this is only your premium for an individual. Family coverage is not included in that calculation. In addition, the employer-provided plan has to provide a minimum value. In other words, employers can't give you a crappy plan and say that that meets the coverage. And in fact, a lot of employers are going to stop providing those crappy plans and let their employees buy coverage on the marketplace in order to meet this requirement. So individual policies can also count towards the individual mandate, and you can buy policies off the marketplace that will qualify. If you have Medicare, Medicaid, CHIP, TRICARE, there's some other forms of coverage that count, but you cannot get tax credits for any of these plans. The only way you can get tax credits is through the marketplace. We've gotten a lot of questions about how people know if their employer-provided insurance meets the mandate, and the answer to that is that you have to ask. All employers' HR departments have had to go through a process of certifying that their plans either meet or don't meet affordability or meet these standards. We all at AIDS Foundation of Chicago got a letter probably a month ago saying your coverage does meet the affordability and minimum value standards. I'm sure most people just threw that out and thought, what the heck is this? Why are they sending this to me? But that was because of the Affordable Care Act, and it said to us, yes, we are going to have coverage that qualifies. So another question is, what determines how much a plan will cost? Plan cost, and in particular premiums, will vary depending on age. An individual who is older can expect to pay up to 3 times more in their premium than somebody who is younger. And actually, this is a real improvement over how insurance was provided before, because in many states, insurers could pretty much charge whatever they wanted to older people. Now there are what's called age bands, so there are some requirements there that are really important. Family size, obviously if you are covering a family of 20, if you're the Duggars, they're going to pay more than an individual. Where you live is really important. It's more expensive in Manhattan to get care than it is in Wyoming. So where you live matters. Your income is going to matter, and that's because lower income people can get subsidies. And probably most challenging for our clients is tobacco use. And plans can charge up to 50% more for somebody who smokes as essentially a penalty and an incentive for people to stop smoking. Now, it's important to know that tobacco cessation, so services to help you quit smoking, are covered by Marketplace and Medicaid, and they are required to be covered. But the higher premiums for tobacco use are going to be a significant challenge for many of our clients, although ADAP will be able in many states to pay those higher premiums in most places. We've gotten some questions about how insurance companies know that you are a smoker or not. And when you go to sign up for coverage, they will ask you, have you used tobacco? The question that the way it's been phrased most often is something along the lines of, have you used tobacco more than 4 times per week in the last 6 months? So it's a frequency question as well as the duration, the time period. We've also had people ask, so how are insurance companies going to know? Well, first of all, you're pretty much signing your life away and saying that you're telling the truth when you click that button at the end of Marketplace sign up to purchase insurance, and there are penalties such as fines for not answering correctly. In addition, insurance companies are allowed to get your medical records from the doctor and see if you have a history of smoking. So there is a way for insurance companies to check. If that's going to really happen, who knows? So another really important question that we need to have an understanding of is what benefits are available on the marketplace. And there are 10 buckets of coverage that are required to be covered in, 10 buckets of benefits that are required to be covered in all plans that are available on the marketplace. There are things like prescription drugs, mental health and substance abuse services, hospitalizations, lab services. What this coverage does is make sure that people aren't being sold crappy plans, and that is a technical term, a crappy plan. But these are really important protections that make sure people are getting good quality plans that cover their medical needs when they buy marketplace plans. Now, of course, within those 10 buckets of benefits, there will be differences, for example, what the formulary covers, what the provider network is, and then, of course, how much it costs. We see significant variation from one plan to another, even if they're the same metal level, so the same tier, looking at bronze plans, when I went onto the Kentucky marketplace, there were some pretty significant differences. And that's really going to be based on the rates that that the insurance plans are able to negotiate with providers, as well as some other factors. Okay, so we're going to stop and take questions. It looks like Melinda has been getting some good ones, so we'll stop and take those. If you can't hear, remember, click on the audio tab and dial the phone number that you see there. That'll help a lot. And then you can download the slides at HIVHealthReform.org. So, Melinda, questions?
Sure. So, John, there have been a lot of questions. I think there was some confusions about what happens as far as the mandate goes, if there are any different kinds of exemptions for states that live in non-Medicaid expansion states. So does the mandate vary in its applicability whether you're living in a Medicaid state or a non-Medicaid state?
Yes, it does. So if you're in a non-Medicaid expansion state, so a state that is not expanding Medicaid, you do not, you obviously can't buy marketplace, you can't get Medicaid coverage, and so the mandate will not apply to you. However, if your income is 100% of federal poverty level or above, you are eligible for subsidies to purchase coverage on the marketplace. And so in that case, excuse me, the mandate will apply to you. Melinda, do you want to add anything to that?
No, I think that the bottom line to understand is that if you're in a whatever state you're in, if you are too low income to pay taxes, you don't have to pay the mandate. And I think that will cover a large part of the Medicaid eligible population.
That is a really good point. Thank you.
Sure. So we had a couple other questions, John, if you can, if you want to take a minute. I think another really good question was around the PSIP plans and what folks should do who are currently on the PSIP plan at this point.
And Melinda, what's a PSIP plan?
So those are the pre-existing condition insurance pools. So again, every state right now has a high-risk insurance pool, either run by the state or run by the feds. So the question is, folks who are on those plans, we know they'll be ending January 1st, so what do those folks need to do?
So those plans will, as Melinda said, end January 1. And they're not just federal plans, but there are also state-run high-risk pool programs, and you should ask your state high-risk pool program what it is doing. Some are ending, some are not. But individuals whose coverage is ending have to apply for marketplace coverage by December 15th at the very, very latest to ensure that coverage begins on January 1. If they don't do that, their coverage will lapse. People whose high-risk pool plan in their state is continuing after January 1 really should look at coverage that's available on the marketplace because it might be cheaper and better.
And then, of course, there's one last question I think is important to point out is just sort of how, and I think you've already addressed this in many ways, but the question is if I have employer-based insurance right now or if I'm on the individual market, so will the mandate apply to me or am I eligible for subsidies in the marketplace? And the answer is, again, you have to look both at the actuarial value of your employer-based plan and then is it affordable? Does it meet the standards within the Act, meaning that is it less than 9.5 or is it less than 8% of your family's income for an individual plan?
So, Melinda, there are people who can't afford their coverage at work. They say, you know, okay, so my employer offers me coverage, but I can't afford it. So somebody in that situation, are they eligible to go buy coverage on the marketplace with subsidies?
So again, it would depend on what that person's kind of concept of affordable is as compared to what the standard is. So if you are having trouble paying your premium just as a matter of course, and it turns out that the premium is actually more than 8% of your income every year, then yes, you would be eligible. But if it's your premium is more than 8% of your less than 8% of your income, then you would not be eligible to purchase the subsidy. So again, there could be some differences between what you think is affordable and sort of what the law states is affordable. But I would again reiterate in every state that the ADAP program and the Ryan White program is still available, as it always has been, to try to fill in some of those gaps. So continue to be paying close attention to what your ADAP program can offer, either on top of your existing coverage or as a substitute in the event that coverage is still unaffordable for you.
Melinda, we just a housekeeping moment. We just got a comment that some people are having trouble hearing. You'll see on your screen that you can open your little tab, your little window there that is popping up with the webinar viewer, and click on the audio tab and then use telephone and dial the phone number you see there if you're having trouble hearing. Melinda, do you want to take one or two more questions and then we go on?
Sure. So there was one question about what happens in states that are not expanding Medicaid where you have individuals below 100% of poverty. Can Ryan White funds be used to purchase insurance for those folks? And the answer is yes. So we can't say for sure what every state is doing, but as far as the federal government is concerned, that is an option for individual state ADAP programs or state Ryan White programs to decide that even though folks below 100%, particularly in non-Medicaid expansion states, are not eligible for subsidies, the ADAP program may still decide to help those individuals purchase premiums on the marketplace. And there was another question, John, about what extent the ACA will address the need for experienced HIV providers, particularly in areas that are limited or rural areas or smaller urban areas. Do you want to talk a little bit about the provider requirements again?
Sure, yes. So there are requirements that plans have meet certain standards for what's called network adequacy. And we are concerned that the standards that the federal government and a lot of states have put out there are not actually that strong. And so they required plans to have contracts with a certain number, usually 20% of the essential community providers in an area, and that includes community health centers, Ryan White providers, TB providers, STD clinics, but it's possible that plans will not have any Ryan White providers at all in their networks. And if that's the case, that's obviously going to be a major concern. And in those situations, you should report those plans to your marketplace, either the state marketplace or the federal marketplace. Let us know about that. We want to know when you encounter plans that are seem to be inadequate. We want to do what we can to help report those plans and get that information to the right people at the state or federal government. So please send information like that our way.
And John, just a couple more questions. Oh,
go ahead. Yeah, it looks like we've gotten a lot of questions about the 8% and 9.5% affordability. Yeah. Can you talk about that, Melinda?
Sure. So I think this is definitely really confusing and in some ways kind of nonsensical and non-intuitive, but such is the law that we're working under. So there are two things in which affordability matters, right? So the first way that affordability matters is as far as the mandate is concerned. So there's an affordability threshold for figuring out whether you are responsible for paying the health insurance mandate. And so the standard for defining affordability as far as whether you have to pay the tax penalty for not having insurance is whether your insurance costs more than 9.5% of your income. So the 9.5% number is tied to whether or not, again, you have to pay this penalty under the mandate as far as affordability is concerned. Now, the 8% standard has to do with your eligibility for subsidies. So if you're paying premiums that are more than, excuse me, I reversed it again. So the
this is called Stump the Chump.
Yes, yes. So if your premium is more than 8% of your income, you do not have to pay the mandate. If your premium is, but there's a different standard for affordability as far as being eligible for subsidies. So for subsidies, so again, whether you qualify for premium assistance, your premium has to be less than 9.5% of your income. And we'll clarify that on the slides. But again, there's a higher affordability threshold in order to access premiums, but a lower threshold as far as not having to pay the penalty. So there is a group of folks with income, whose insurance is between 8% and 9.5% of their income, where they don't have to pay the mandate, but they're not eligible for the subsidy. So I know that's confusing, and I apologize for botching it again in the explanation, but we'll make sure that that's very clear on the slides.
And we'll also send out a clarification when we send a follow-up email with the links to the recording. So that's another way. All right, so let's plow on here. So here we have a man both cleaning and holding the baby. We can all do it. Moving on to how clients can afford the marketplace. There's premium subsidies as well as cost-sharing reductions. Here we have the metal level plans again, so keep these in mind. And we're going to start with talking about premium tax credits. Remember that premiums are the fee that you need to pay to purchase coverage in the first place. And that's usually paid monthly and sometimes can be paid quarterly or annually, but in most cases it's paid monthly. Tax credits are available if you purchase coverage through the marketplace for people who earn between 100 and 400% of poverty. And this reduces the amount you pay in the premium depending on your income. So people at the lower end of the income scale who make 100% of poverty pay 2% of their income as in premiums. So it's based on a percentage of your income. And this is just what is in the law. On the high end, you can pay up to 9.5% of your income in premiums. And that's at 400% of poverty or above. So you can take the tax credits in advance, so it'll lower your monthly premiums, and we'll have some examples of that, or wait till the end of the year and get a refund. And then in a lot of states, ADAPs are going to help to pay the cost of premiums, and we'll talk about that later too. So let's talk about Jane. Jane lives in Chicago. These are actually California rates because we couldn't get on the marketplace for Illinois. And so here's her income. She's 30. Her monthly premium is $258 a month. And we let the California marketplace do its calculating, and her subsidy would be $112. And so that's about 2.5% of her income. And she pays, I'm sorry, I got that wrong. She pays $146 a month, which is about 2.5% of her income, and her subsidy makes up the rest. So she pays $146 to the plan, and then the federal government, Uncle Sam, pays $112 a month directly to the plan, and that's how the subsidies work. Next. So you can take your premium now or later, and this is a really important idea to understand. This works a lot like the Earned Income Tax Credit, which many of us are familiar with, so keep that in mind. You can either take the credit now, so you can get it in advance, just like you get more of the Earned Income Tax Credit in your paycheck every month, or you can get it at the end of the year when you file taxes. Most ADAPs are going to require their clients to take the advance premium tax credit, and that's because it will reduce the amount of money that ADAPs have to pay now out of pocket. And let's be honest here, ADAPs are not going to be able to chase people down to get refunds from clients. And if individuals choose to take the credit at tax time, they're going to have to pay the full cost of the premium up front. So we'll see that in a second. And it's important to remember the feds pay the premium subsidy directly to the plan and not the individual if you take the tax credit now. So go ahead. So, oh, and in addition, it's really, really, really important, no matter which option you choose, that you inform the marketplace whenever there's changes in income. Because if your income goes up, your subsidy will go down, right? So you're earning more money. The federal government pays you less to help you afford coverage. Also, if your income goes down, your subsidy is going to go up, right? All of this is going to be reconciled when individuals file their taxes. And this is one of those, the feds are going to catch up with you. And you're going to have to pay at the end, or it's possible that you can get money back at the end. So to be safe, if somebody's income changes, it's really important that they report those changes to the marketplace. And individuals might want to slightly overestimate their income, particularly if their income changes a lot, so that they can get a slightly smaller subsidy. So they basically have to pay a little more now, and then they would get a little more money back later when taxes are filed. That'll help them to avoid owing a big check when taxes are filed. So go ahead. So what happens if Jane doesn't take the tax credit in advance? This is the same example. You see that she has to pay the whole premium monthly upfront, $258. She would get a $1,344 tax credit, which is $112 a month times 12, when she files her taxes, which is really, you know, for her, it's really not going to be affordable for her to pay all of this out of pocket. So another way that the marketplace makes private insurance more affordable is through lower cost sharing. And remember, everybody has to pay two forms of, they have to pay in two ways to get coverage. The first is premiums, which is the monthly fee you get for coverage, which we just talked about. And then there's out-of-pocket costs. That's what you pay when you actually get care. So there's your deductible, there's co-pays, and then there's co-insurance. So deductibles are the amount that you have to pay before the plan pays anything. Sometimes it's $1,000 that you have to pay before the plan starts paying. A copay is a usually small amount, like $5, $10, $20, or coinsurance, which is a percentage of the medical charge. So out-of-pocket spending is capped at $6,350 per year for higher income individuals. This is huge because there used to be plans that would be tens of thousands of dollars in out-of-pocket costs that individuals might take, and they often might not understand how much they might have to pay for coverage. Remember that this is a cap. This is the maximum that individuals will pay. So many people will not use that much medical care. So people who earn between 100 and 250% of federal poverty level pay lower out-of-pocket costs. So for example, you pay $2,100 if your income is between 100 and 200% of poverty. 200 to 250, you pay no more than $3,200, and the subsidies end at 250% of poverty. Yes, we agree that that's really low and they should go higher. But it's really, really important. This is really, really, really important. Reduced cost sharing only comes if you pick the silver plan. So here we have these plans again. I know you're tired of seeing this slide, but it gets fancy with some things disappear. You have to pick silver to get help paying out-of-pocket costs, and that is going to be really critical, and we'll see why here. So let's look at Jane again. This is why it's important for people who earn less than 250% of FPL to pick a silver plan. So her monthly premium is $258. Everything is the same. With the silver plan, her max cost sharing would be $2,100. If she screwed up and picked a gold plan, or maybe for some other reason she wanted to pick a gold plan, it would be $6,350. And that's really going to matter not so much with HIV drugs necessarily, but with other medical care or drugs that she gets. So we will come back to ADAP. So let's stop and take some questions, Melinda.
So there was a question about current COBRA covered individuals. And I think the question is, yeah, go ahead, John.
Yes, so COBRA. COBRA is, what does COBRA stand for, Melinda?
You know, I can't remember the exact terminology, but COBRA is the coverage that you get after you've lost your job, and your employer is required to continue that coverage for a certain amount of time, albeit at a higher cost for you. But that's the insurance that's offered, again, when you lose your job, and you can keep the insurance portion for a few months.
Great. So it may be that individuals who are on COBRA have less expensive options through the marketplace. And one of the triggers for being able to buy insurance outside the open enrollment period is losing your job. So if you lose your job, you can still get COBRA coverage. It will still exist. But you can also go shop on the marketplace, and you may get cheaper, better coverage through the marketplace. Some other reasons that you can get coverage, that you can buy marketplace plans outside the open enrollment period is for significant life events, like you get married, you get divorced, you have another child, you adopt, you go out and you get a new job and you work for yourself or you work for a company that doesn't provide insurance, you can go get marketplace coverage. Any other questions we want to take now, Melinda?
Yeah, so in regards to income, and I want to clarify, we don't have time in this webinar to really go into the details of exactly how income is calculated, but you should know that the sort of buzzword for income, or the way that it's going to be calculated, is something called Modified Adjusted Gross Income, or MAGI. It's very similar to the number that you would get as your adjusted gross income, and it's an annual figure on your tax returns. But again, we'll be able to provide resources for folks because you're better off kind of asking your navigator programs in states about this, and there are also some other resources we can point you to without getting into the details. But I think one question is important, which was, if you have changes in income, do you mean, John, that if your monthly income changes, or do you mean your annual income, or what's the kind of figures that people are talking about with regard to monthly versus annual?
So there's a couple of ways to think about this. One is that if individuals know what their income is going to be up front, you can, when you go to the marketplace, you can either take last year's income if you think your income is not going to change, and the marketplace system will go scoop that up from the IRS website if you filed your taxes, or you can sit down with your pay stubs and enter your income. You can also adjust that income. So if you're somebody who maybe is a seasonal worker, so maybe you work in an ice cream shop on the boardwalk, and you know that in the winter you're not going to be working much, so your income's going to be low. So when January comes around, you might want to report that your income is based on working, maybe 5 hours a week. You know that once summer comes, however, there's going to be more demand for your services. You're going to work more. So you would call the marketplace and say, hey, my income is changing. I'm going to be working, 40 hours a week now, so please adjust my subsidy. Melinda, we've gotten a couple questions about people who earn just cash wages. How are those handled?
So again, actually, I think what's important to keep in mind about income is it's based on an annual figure, right? So yes, if you have adjustments in your monthly income that vary month to month, and you think that's going to change what your estimate was for your overall annual income, then you should be reporting those changes. But again, because the figure is a year-long estimate, that is supposed to take into account those fluctuations in income, because you know as a worker that you can predict those for the most part. It's only if your income changes from that annual estimate that you provided that you really need to report it. So that's one thing I just wanted to clarify. And I'm sorry, John, could you repeat your question?
I don't remember what it was.
Okay, well, here's another question that Here's another question I think it's important to understand. What happens to HIV clients who feel they can't afford to buy insurance in the marketplace, so they choose not to, so they don't have insurance, but they still come in for Ryan White program services in 2014?
Excuse me, that is a very good question. And we encourage everybody to visit HRSA's Affordable Care Act website, which is hab.hrsa.gov/Affordable Care Act, easy to remember. HRSA has done about 6 or 7 different policy clarifications on the Affordable Care Act, which are pretty short and readable, so download those and read them. They've also done a number of webinars on the Affordable Care Act, and they just did one maybe 2 weeks ago where they talked about this very issue. So HRSA's policy HRSA has stated very clearly that agencies have to, quote unquote, vigorously pursue eligibility in other programs, and they vigorously pursue is their term. Again, we'll send the HRSA website out to everybody by chat. It's hab.hrsa.gov/Affordable Care Act. HRSA, not HE. Okay, HRSA.gov. So as long as you vigorously pursue eligibility for any client who might be eligible, and you have to have standard operating policies in place that indicate how you are going to inform people about programs that they might be eligible for, how you're going to help them enroll, how you're going to follow up to make sure they enroll. And if you document these processes, so you note, I met with Joe on Tuesday and informed him of the requirement that he get coverage through the ACA and the penalties for not getting coverage. And if it turns out, so you do all those things, so you have policies in place, you document what you did with every client, and then you have all that together, and the client still doesn't get coverage, then you are able to provide services to that client. And that should go for both ADAP and for the marketplace. We have seen, however, some somewhat threatening letters from ADAPs saying that if individuals don't get marketplace coverage or don't get Medicaid, that they will be disenrolled from ADAP. ADAPs are under a lot of pressure from the Inspector General to make sure that they're following payer of last resort. So they're trying to balance the mandate that they have to live with, that everybody has to access other coverage if it's available, and the public health charge that we have with HIV to ensure that everybody is in treatment. And we know the importance of treatment for people with HIV. So this is really an area where we are going to have to really ask a lot of questions of HRSA. And sending HRSA questions with individual scenarios is going to be really important. It's going to be important to document what HRSA tells you in response and share those answers, particularly with us, because we're really interested in seeing what they say. So, Melinda, do you want to add anything to that?
No, I think that's a pretty good summary. Okay.
Great.
So,
thank you. So,
sure.
Should we go ahead on, or should we take questions?
Yes, I think we can go on. Mm-hmm.
Okay. We will go on then. So the next question is, how can ADAP work with marketplace plans to make coverage more affordable? And here we have Wonder Woman. So go ahead. So the Ryan White and ADAP programs play really critical roles to wrap around both Medicaid and marketplace coverage. But it's important to remember that every ADAP and every state or city Ryan White program is different, has different funding demands, and is at different stages of readiness for the Affordable Care Act. So ADAP and Ryan White are allowed to pay premiums, out-of-pocket costs for drugs that are on the ADAP formulary, and out-of-pocket costs for HIV-related medical expenses. So if you go to your HIV doctor, ADAP can pay your portion of cost sharing. But not every state has the ability to do all these things. You need to ask your state ADAP and Ryan White programs what they plan to do. Keep in mind that ADAP staff haven't been able to look at plans either, because in most cases they haven't had access to the marketplaces, just like we haven't. So many state ADAP programs are working right now to assess plans, and they're having the same problems we all are getting marketplace plans. And we don't know what specific states are doing, unfortunately, because we don't have the resources to track every state. We encourage you to ask your state ADAP what they're doing. Sad face. Okay, so there's some important ADAP considerations, and these are going to influence enrollment and enrollment choices. And so first off, is the client eligible for ADAP? If their income is above the ADAP income level, maybe it's 200% in your state, then and the person's income is 300% of poverty, you don't need to worry about ADAP coverage, and they have a lot more choices in marketplace coverage. However, if they are eligible for ADAP, you need to keep in mind which plans ADAP will coordinate with. You should know if individuals are required to take the advanced premium tax credit. They probably will be. And some states are requiring clients to purchase silver level plans in order to take advantage of that lower cost sharing. That's going to differ from state to state. So let's look at an example. Here we are back to good old Jane, and go ahead. So what Ryan White can do in some states with some plans is pay Jane's portion of her premium to the health insurance plan. So Ryan White could pay that $146 that otherwise she would owe directly to the health insurance company, and she would pay no premium. And again, that's only going to be in some states with some plans. And nearly all states have caps on how much they will pay per month for coverage, so it's important to know what those are. So let's also look at ADAP with out-of-pocket cost sharing help. So remember, ADAPs can pay individuals' portions of or individuals' out-of-pocket costs for medications that are on the ADAP formulary. So if Jane's ADAP is able to do that, ADAP and Ryan White would pay the out-of-pocket costs for HIV medical visits as well as the out-of-pocket costs for medications that are on the ADAP formulary. And Jane would have to pay for drugs that are not on the ADAP formulary, medical visits for other conditions, for hospital bills, for other services. And remember, in this case, she picked the silver plan, so her cost sharing was reduced to $2,100. Remember, not all state ADAPs are able to do this, and but they should be working to develop this capacity, and you as advocates should be pushing them to develop this capacity. Go ahead. So we're going to stop or change directions a little bit and talk about some enrollment tips. There are a couple here that are pretty important. And first off, people with HIV should not enroll in the marketplace on October 1 or until they hear which plans ADAP is coordinating with, if ADAP is going to be able to do that. So find out what your state ADAP program is doing before you help anybody sign up for marketplace coverage. Once you pay your first month's premium, you cannot switch plans. So if somebody enrolls tomorrow and they find out on Monday that ADAP is not covering that plan and they've already paid their premium, they are going to be out of luck. It's also not going to be easy to switch a plan even before you've paid your first month's premium. So it's critical to get in the right plan the first time. Consult with HIV providers before enrolling and find somebody who has HIV expertise. There's going to be a lot of people out there who are providing enrollment help. People are going to be out everywhere, and we'll talk about the various enrollment assistance programs, but find somebody, an organization, to link people to that know HIV issues and have some HIV-specific training. And then be on the lookout for scams. We have heard about scams already. The Attorney General in Illinois has put out a call for people to report scams. Make sure clients know that they should not give their phone number to somebody who calls them. Should not give out their Social Security numbers for somebody who calls them and says, I can help you enroll, and oh, by the way, you can pay me $300 to do that. Individuals should not have to pay to enroll, and they should be really careful with their personal information. And a couple of musts for people with HIV. People with HIV must enroll in a plan that includes their current providers, both primary care, specialist, and pharmacy, in network so that they can pay the lowest possible out-of-pocket costs. They should enroll in a plan that coordinate with ADAP if applicable in their state. And they should enroll in a plan that includes their medications on the formulary, on the plan formulary. All plans on the marketplace have a link so you can go to the formulary, type in the drugs, and see what cost sharing or co-insurance tier they are on. And the formulary, the tier that a drug is on is going to be particularly important for non-HIV drugs that are not covered by ADAP, particularly for other chronic conditions, because clients are going to have to pay out of pocket for those. So getting enrollment help. There's a lot of enrollment help out there. And one website where you can look up enrollment help is local.healthcare.gov. However, that is only for federally run marketplace states. If you go to that website and nothing comes up, go to your state marketplace, and there should be a link there to look for enrollment help. We encourage everybody to become a certified application counselor organization. It is a simple application, although it does take a while, apparently, for the federal government to process those applications, so be patient, please. But it is a brief 4 or 5 hour training, and you can be certified to help people enroll. There's also federal navigators. There are state, what's called in-person counselors who are out there. There's a lot of different funding streams for enrollment helpers, but they're all basically doing the same thing. And we did a webinar on August 29th about enrollment and what organizations can do to get ready for enrollment, so we encourage you to visit that. And so we're coming to the end of slides, so we're going to go back to questions in a minute. But here's our contact information for me and Melinda. We encourage you to check out HIVHealthReform.org, and particularly the resources tab, because there's a lot of good information there and good links that you can sort through. We encourage you to download and share the presentation and the recording. We will send you an email when the recording is available. When you sign off, you'll get a couple quick questions and a survey. We really, really want your feedback, so please take a second to take that. And then we want to remind you to register for the upcoming webinars on the 23rd and 14th, depending on what kind of state you're in, and stay tuned for announcements about other webinars. So you can submit questions. We will do our best, if we don't get to your question, to follow up. We have about 18 minutes left, so let's go for it, Melinda. What are some questions?
Sure. So one question is, how can a newly diagnosed client change their plan after the enrollment period is over if they find out they are HIV positive, having already signed up for coverage that doesn't have HIV coverage? So I think the question here is really, again, if you sign up for a particular plan and then you find out later that you have an illness or something else health-related that would cause you to feel like a different plan would be better for you, what can you do, if anything?
So unfortunately, the answer to that is not much. And it's going to be very difficult for individuals to change plans once they've paid that first month premium. So it's likely that individuals will just have to do their best. And that, I think, would be a situation where an individual should ask their state ADAP if their state ADAP will provide them drugs anyway. Their ADAPs may be able to do that. They may have that capacity. In addition, patient assistance programs will continue to be available. So that'll be for people who don't get insurance coverage, although there's many questions about what those programs are going to look like. And that's a stay tuned. But there will be some form of patient assistance program available. So really the options there are going to be to kind of ask ADAP and see if they will be able to step in. And we think in some cases they will.
And just to be clear, every plan on the marketplace is not permitted to discriminate. I mean, one of the big things about this new health law is that discrimination on the basis of a pre-existing or newly diagnosed conditions like HIV is no longer allowed. So, you know, if you're somebody who's diagnosed with HIV and you already have a health plan, the chances of that health plan excluding services for HIV are very low. So I would suspect that if you are enrolled in a qualified health plan on the marketplace, that plan is going to have some sort of HIV coverage, and again, that's where you have ADAP and Ryan White to hopefully fill some of those gaps as well.
But it is possible that somebody's HIV medications would be in a very high tier with, 30 or 40% coinsurance, and 30 or 40% of $1,000 a month is a lot of money, which could be unaffordable. So
correct.
That is going to be one of the challenges that we face with health reform.
And so we had another question. I think, John, this was your earlier question, so I'll throw it back to you, or if you want, I can answer. How is eligibility for tax credits determined if a person works for cash?
So we did, you know what, Melinda, why don't you answer that?
Sure. So I think the simple answer is that your tax credit, the amount of your tax credit is based on your annual income, and that's not really dependent on whether you're earning cash annually or whether you're earning other kinds of income. So if you work for cash, you do have to file taxes if that's something that you're required to do. So if you're making enough money to file taxes, you have to do that in order to kind of make this system work for you and in order not to be outside of the law. But if you are earning cash and you don't have taxes, for example, from last year because perhaps it was too low, again, there are other ways to estimate your income that don't require verification from last year's tax return. So in terms of the difference between how you earn your money, I mean, again, it's based on an annual estimate of what the total amount you're earning is. So hopefully that clarifies it a little bit.
Great, thank you. That's really helpful clarification, Melinda. So here's a question that I don't know the answer to. If a patient is in a 2-year waiting period for Medicare, what options does that person have? Can they get marketplace coverage during that 2-year waiting period?
Yes.
With subsidies?
Right. So the question here, I think, is when you become disabled and when you're, so as far as the government concerned, you've met the standards for disability, there's 2 years before you're eligible for Medicare coverage. And that waiting period, during that period, you're not Medicare eligible, so you're not on Medicare. So that shouldn't affect your ability to be eligible for subsidies if you meet all the other requirements that we've been talking about as far as not having access to affordable employer and sponsored insurance and meeting the residency requirements and so forth. So again, if you do not have access to insurance, even if you're in a so-called waiting period, the threshold question is, are you able to enroll in that insurance plan? And if you can't, for example, it doesn't matter which stage of the waiting period you're in. The point is that you're not enrolled in Medicare. and you couldn't be.
Great. That's a very that's very helpful. Thank you, Melinda, and thank you for that question, because we love questions that, or I love questions that I haven't seen before or thought about. So
here's a good question.
All right, Melinda, you pick a question.
Okay, I got one for you. What if you get a marketplace plan based on what your estimate of your own income was, and then you report an increase in your income, and this means you don't qualify for subsidies anymore? What happens at that point?
That is a really good question. The marketplace subsidies top out, so you're not eligible for subsidies anymore after you hit 400% of federal poverty level. So that's about $46,000 a year. And at that point, I guess the government, when the Affordable Care Act was put together, the assumption was that if you earn above 400% of poverty, then you can afford your medical care. And in those situations, individuals will be subject to the requirement to have health insurance. They could choose to go uninsured and pay the penalty, which will be $95 next year, or up to 2.5% of income. So individuals will, in that case, be able to continue coverage and pay the cost themselves, or go without insurance. Do you want to add anything to that, Melinda?
Yeah, I just want to clarify one thing. So just to start out with the penalty as far as this coming year, I just want to make one clarification. So yes, the answer is $95, or the penalty is 1% of your income, whichever is higher. So again, there's actually a more complicated standard as far as what the penalty is for this particular year, and then eventually in 2 years, the penalty will go up to 2.5% of your income. So just to clarify that status. And I think the other question about what happens if your income changes during the year, I think there are two answers to that, depending on whether that person has asked to have tax credits applied in advance, so they're paying a lower monthly premium, or are they paying tax, or have they chosen to take the tax credit after the year is over. So if they've chosen to take the tax credit after the year is over, then there's not going to be too much of a change, right? Because that person isn't actually receiving any subsidies, and what would happen is the amount of their refund that would, sort of constitute what their premium assistance would be would decrease, right, at the end of the year, and so your rebate would be smaller. So if you're somebody who has chosen to take the subsidies in advance, so you're paying a lower monthly premium, once you report a lower income, then your premiums would go up, and that's when you have those choices that John mentioned. Either you continue to pay your higher premiums, or and perhaps you're still eligible for assistance from ADAP with your premiums. It just depends on what kind of numbers we're talking about. Or again, you may decide not to have insurance and opt to pay the penalty. So just a little bit of a clarification.
Thank you for correcting me, Melinda, about the penalties. This is why it's always great to have a lawyer on the webinar.
No problem.
So here's, all right, my turn to pick a question. Is there an annual recertification period, or is there a, and the answer to that is yes. There will be an open enrollment period for the marketplace, and that is aligned with the Medicare Part D open enrollment period, which is in October and November of every year. So we can all expect that we're going to be really busy helping everybody doing their open enrollment. And that's the point where you can choose a new plan, a different plan, you can change metal tiers, you can change companies, and you will also at that point adjust for any changes in income. And Medicaid recertification will follow its own timeline. That's an annual process, and how that actually works differs from state to state.
And just so we're clear, there are some exceptions to that. So the law did write in to sort of try to anticipate things that might change for a person. So if outside of an open enrollment period you lose access to employer-sponsored coverage, for example, that would be a time where you would meet an exception and be able to enroll outside of open enrollment. And there's various other exceptions that also may apply. So for example, if you give birth or if you get married, those kinds of things. And states also have the ability to add additional exceptions. So that's actually both a federal question, yes, but look to your state and talk to your state navigators about what other exceptions might be as far as being able to enroll outside of open enrollment.
That's a really good point. Thank you.
Sure. So another question that we got is, are there any details on state premium sponsorship programs? So I'm going to interpret that in two ways. One is, I think it's a question about, again, Ryan White and ADAP, and I think we just want to stress one more time, you know, ADAPs are in many cases in the same place that we are. They're just starting to look at these plans. So the answer is no, we don't have exact details. Each state is different. Some states are further along in their determinations than others, and I would really encourage you, we both encourage you to talk directly to your state ADAP or your state Ryan White program about that. I just want to flag another really good resource on this is, of course, NASDAD, the National Association of State and Territorial AIDS Directors. They're also trying to collect this information, but even their information is only going to be as good as what can be reported. So I think paying attention to your particular state ADAP is going to be really critical in that respect. And then as far as state premium sponsorship programs, I can only, you know, if you're not talking about ADAP or Ryan White, the only example I can think of is here in Massachusetts, we actually do have a state wraparound program that goes on top of the federal subsidies, but that's unique to Massachusetts, and I'm not sure if any other states are also doing that, but again, that would be a state-specific question.
Great, thank you, Melinda.
Sure.
We got a question about how ADAPs will pay for out-of-pocket medical visits. There are a couple states that do this, and I know many more are looking into this. But one state that I know of, there are specific providers, which are basically the Ryan White funded providers. And if somebody with HIV gets care there, the individual essentially has an insurance card that says they're enrolled in the Ryan White insurance payment program, and the provider uses that to send a bill to the insurance payment program, which they pay. So that's an example of a state that has a relatively limited provider network, and that may be the kind of arrangement that many states create because it is relatively manageable. There are other states that are looking at electronic systems, so that somebody, so that it all happens automatically behind the scenes, and individuals don't have to can go to any participating provider. So that really varies from state to state, and we are planning a webinar coming up on ways that ADAPs can respond to healthcare reform. So that's something that we'll cover in more detail then.
And just to add to that, somebody actually in the questions raised a really good point, which is that, look, ADAPs are going to continue, and Ryan White programs are going to continue this year to provide many of the same services that they have in the past. I mean, obviously depending on funding, as we know, which at the federal level is at a critical point at this moment. But, for example, there may be services that even if you're insured, insurance plans just don't cover. So, for example, there could be a difference between what your insurance plan considers to be something like case management versus the level and comprehensiveness of case management you get from your Ryan White provider. And so if it's a service that you need, that you're eligible for, that, again, your health plan doesn't cover, that service can be continued to be provided by your Ryan White program. So, again, things like home-delivered meals and so forth, and it's going to vary by state, obviously, but those coverage completion services, as we're now sort of talking about them, can continue as well.
And we've been getting some great comments on issues like coverage completion from some of our audience members. So thank you, Heather, for that. We probably have time for one more question, Melinda, and some closing comments. So why don't you pick?
Okay, I'm scrolling through.
Okay, how about I pick one?
Yeah, sorry, I'm having trouble reading all the questions as they come in.
I know, there's a lot to cover here. So how do you, so here's a scenario. The mom is a legal immigrant. The dad is undocumented and they have 2 kids who are U.S. citizens. Whose income counts in a situation like this? And can you walk us through a scenario like this where there's documented and undocumented members of the family in 3 minutes or less?
So the answer is no. I actually cannot do that. I would be happy to follow up with this person offline. I want to double check on the immigration scenario. My best guess would be that undocumented dad's income wouldn't count, but I really would not. I don't want to answer that right now because I'd like to follow up with you offline to talk through that a little bit more because it is complicated.
This is an example of the many, many issues that we just don't have, just don't know the answers to. So thank you for that question. It's a really good one, and we know we're going to have a lot of situations like this. And these are some of the reasons that it's really important to get experienced enrollment assistance and get that training. So,
and I can't say enough again for folks to really, make use of all of the services that are in place now to help you with these kinds of questions. I mean, the reality is states may also kind of add additional requirements here and there around certain issues. So I think it's very important to touch base with both your state ADAP, but also the navigators, the certified application counselors in your state for assistance, because that's what they're there for. And quite frankly, if you're a navigator, you're getting money to do this. So make them earn it, make sure that you take advantage of those and ask these kinds of questions because they are really important, and it is everybody's job to try to get them answered.
And we did go into an hour and a half of detail about readiness for healthcare reform, including enrollment, on the 29th of August, so we encourage you to go back to that. Also, if folks want to really dig deep into some of these details, the Center on Budget and Policy Priorities has a website called, and a whole series called Beyond the Basics, and we have a link to that on HIVHealthReform.org. They have about 5 or 6 modules that go really, really in depth into how income's calculated, family size, premiums, premium subsidies, go through tons of scenarios. So there's great information there. And I encourage folks who want to learn more to look at those information. So Melinda, thank you for joining us today and helping to field questions and be a great co-presenter with a good sense of humor. It was a lot more fun than presenting on my own, so I hope you had fun too. Please follow up with both of us by email or phone or carrier pigeon if you have questions. We'll do our best to answer. Melinda, any closing comments?
No, I just want to say thank you all, and we have to keep in mind the bigger picture here. As John started out at the beginning, I think this is really exciting. I think it's really a critical moment in history, and I think it's something that we all should be proud of, because I know that every one of us on our webinar has been working for this for a very long time. And then I think the caveat is, of course, that there will be glitches, and we know that there are going to be some gaps, particularly in non-expansion Medicaid states. And so we're going to need to work extra hard in those states to plug those gaps and to push those states forward. But again, I think it's an exciting time, and we have to just do the best that we can, and to continue to really share best practices with one another, and to share your stories with HIVHealthReform.org so that we can continue to compile resources and be resources for one another.
Awesome. Thank you so much, Melinda, and thank you, everybody, and have a great rest of the day. Bye-bye.